Greetings, everyone. Welcome to the National Hispanic Council on Aging's virtual legislative briefing. My name is Jeff Cruz, and I'm the Executive Director of the Latinos for Secure Retirement Coalition. And it's my great honor and pleasure to moderate today's event and join you all for this virtual briefing. The National Hispanic Council on Aging's legislative briefings are a really important platform to kind of educate lawmakers and their staff on key issues impacting Latino communities today, and not just to talk about it, but to facilitate solutions that together we could work to enact on a policy level. We have a great lineup today, but I do want to flag that this is part of a series, and the next National Hispanic Council on Aging briefing will be a hybrid. You could tune in virtually or join us on the Hill, and it's going to be at 10 a.m. on April 21st. So please, save that date in your calendar, mark it, and additional information will be coming. I also want to flag that National Hispanic Council on Aging and Latinos for Secure Retirement, we are doing an event at 9 a.m. next Thursday, March 5th, focusing on SSI, the Supplemental Security Income Program. And so we will be sending information about that later today. So you can mark your calendar if you want to tune in for that, 9 a.m. March 5th. But for this legislative briefing, we have some key topics that will really make a long-lasting impact if we could get them addressed on the policy level. For example, we are going to talk about the obesity epidemic, which is, of course, nuanced and very complicated. But one issue is we've seen the rise of counterfeit anti-obesity medications, which is having severe consequences for our community. We are going to talk about the 340B drug pricing program, which could benefit our program, but we've seen some misuse that we need to get addressed. We're also going to talk about federal changes to guidance on childhood and adult immunizations, which of course are very important. We're seeing measles outbreaks in several communities. And we're going to talk about other challenges for the health of our communities, in particular, the importance of reauthorizing the Older Americans Act, which is really the foundation for federal, state, and local nonprofit organizations to deliver home and community-based services critical to older adults and their caregivers. And so, without it, older adults aren't going to get the support they need and are really going to suffer. And so I'm really delighted that Dr. Yanira Cruz, who is going to be the first one I'm going to introduce here in a second. She is the president and CEO of the National Hispanic Council on Aging. She's one of our nation's foremost advocates and spokespeople for older adults, and she's put together a great program, and it's absolutely amazing, as you guys will see in a minute. And so let me introduce Dr. Yanira Cruz to open us up.
Thank you, Jeff, for your time today and your contributions to our nation, to making sure that not only the health, but also the economic security of our communities across the country are solid and sound. So thank you for your leadership. And hello, everyone. And thank you, of course, to the panelists for your contributions as well, for making time to making it this morning. And I'm honored. Of course, I'm honored to welcome you to our first legislative briefing of the year. We're very proud to host these events and be able to meet with our community members, with fellow advocates, with legislators, and these briefings are really an opportunity for us to share the latest policy insights impacting the health and well-being of communities across the country, and the issues that we are dealing with and coping with and hearing here in Washington, D.C. So I think it's a great platform to be able to diffuse and disseminate information across the country. And of course, together we can facilitate real change in U.S. policy that reflects the needs of communities across the country. And that's why I'm really thrilled and excited that today we have a great panel of advocates, of experts who work each day to make this this country a better place to be. And at the National Hispanic Council on Aging, part of our job is to educate, to advocate for and advance policies that promote the health of Latinos, that promote the health of older adults and caregivers. And today we gather at a pivotal moment. We know that across the country, Latino families are facing multiple interconnected challenges that require thoughtful responses from policymakers. And so one of the most urgent issues we are discussing today is the rise of counterfeit anti-obesity medications. And we have with us this morning Dr. Serrano, who will tell us more in a bit about this situation. Obesity is a serious health concern for our nation, especially for Latino children and adults. It's a debilitating chronic disease that leads to a higher risk of other chronic diseases like diabetes, cardiovascular disease. And we also know that Latino communities see a higher rate of obesity than other demographics. And so to address the obesity epidemic, we have long supported the Treat and Reduce Obesity Act, which would help expand coverage of anti-obesity medications and services to better confront the disease with not just behavioral solutions, but also pharmaceutical treatment. And these measures will reduce preventable disease and improve quality of life for millions of older adults and their caregivers, whose situations simply do not allow them the privilege to confront this disease with just diet and exercise. We also know that the promise of affordable medications depends on a drug pricing system that actually saves money for patients. And the 340B drug pricing program was intended to help with medication affordability by allowing healthcare institutions in areas with low-income populations to purchase medications at deep discounts and reinvest those savings in care for low-income patients. And we've heard, in the last several months and years that instead third-party contract pharmacies have captured most of these discounts, while patients face high out-of-pocket costs, especially older adults with chronic illnesses. And so the 340B Access Act would ensure that savings benefit underserved communities by increasing transparency and accountability for participating pharmacies. And the final matter of public health that I would like to raise today is vaccination. Immunization is one of the most effective preventive tools in public health. Throughout life, vaccines have protected individuals, families, and communities from deadly and costly diseases. However, disparities in adult immunization rates persist among many communities, including Latino older adults. We at the National Hispanic Council on Aging continue to advocate for culturally competent outreach and stronger policies that make it easier for older adults to access and understand the importance of vaccination. And so these topics are not abstract policy debates. They affect people. Every aspect of everyday life for Latino older adults, their caregivers, and their families. They touch on issues of access, of issues of dignity, financial security, and the ability to live long, healthy lives with the support and care that our communities deserve. And so before I finish, I would like to bring your attention to the matter of Latino civic participation. Latino voters are one of the fastest growing segments of the electorate, and their voices are crucial in shaping policies that impact their health, their future, and the future of their children and grandchildren. Informed, engaged, and well-represented communities lead to policy decisions that better reflect the lived realities of our families. And so this morning, we encourage everyone here, as well as the communities you represent and serve, to stay engaged, stay informed, and active in our democracy. Together, we can ensure that the voices of Latino older adults and their loved ones are heard and reflected in policies that promote their good health, their good well-being, and equity. Thank you so much for being here, for allowing me the space to offer this welcoming remarks. Muchísimas gracias. And I also invite you to stay connected with the work of the National Hispanic Council on Aging by following our social media at NHCOA.org. And with that, I turn it over to our moderator, Jeff, who will take us from here. Thank you.
Yeah, thank you, Dr. Cruz, for that important reminder. We're going to hear in a minute from our first speaker, Dr. Ray Serrano, who's the Director of Research and Policy for the League of United Latin American Citizens, or LULAC. For those that don't know them, they're the nation's oldest and largest civil rights advocacy organization. And I especially want to welcome Ray here because they just finished their conference earlier this week. It is one of the largest gathering of Latino leaders in the country. And a lot of people, after they do a conference, they try to go to a beach and, sip pina coladas. And Dr. Ray Serrano, instead of doing that, is 2 days after this huge conference ended, is here joining us because he's so passionate about advocating for issues impacting our community. So thank you for joining us, Dr. Serrano.
Thank you so much. I'm hoping I can get the slides to work here. I'm here with my colleague, Andrea Hernandez Gomez. Andrea is from the University of Central Florida, and she came to us last year as a research and policy fellow. She's a biochemistry and biomedical sciences student, and she has a wealth of knowledge from the more scientific side of things. One of the things we've been working on together is a report on this actual issue of counterfeit and illegally compounded medications on GLP-1s, which I think I would argue that is actually kind of the tip of the spear for a lot more drugs that are coming into the market. So I guess we can go to the next slide, or I guess I'm not sure how or do I share my screen? Okay, there we go. Perfect. So I titled this basically Unregulated, Unchecked, and Unsafe. And the idea behind it is that there's two different things that are happening here. There's a flat out counterfeit GLP-1s, basically fake drugs. And then there's compounded drugs. And I'll go into what that means later. But what we are seeing is that there's a surge of these two. GLP-1 drugs were basically weight loss drugs. You probably know them as Ozempic, Mounjaro, Wegovy. They're kind of this revolutionary drugs that come into the space to address the issue of obesity. Unfortunately, they've been very expensive and out of access for folks. We've been trying to get Medicaid and Medicare to cover it, private insurance companies to cover it. Many times they don't cover it, and so folks don't get it. Latinos, if you line up all the uninsured people in the United States, 40% of those people are Latino, 1 in 6. Latinos don't have insurance, and those that do have insurance have Medicaid, which often doesn't cover this. So it is a big challenge to try to get access to these critical drugs. And unfortunately, the one that's filled the void has been this surge of kind of counterfeit and compounded drugs. So I'm going to turn it over to Andrea for this first section.
Awesome. Thank you, Ray, and thank you guys for having me. So, it's well documented that obesity disproportionately affects Black and Latino communities. And so currently now 1/3 of Black and Latino children are obese, and in just a few years, we're moving towards 50% of the US population to be considered obese. And so we know that some of the key drivers on this include food insecurity and limited access to healthy foods. Neighborhoods usually populated by predominantly minorities like Latinos tend to be food deserts, which if you guys don't know the definition, it's basically typically underinvested urban or remote rural communities that lack supermarkets, with affordable and nutritious food. Apart from chronic stress and mental health that disproportionately affects our communities, as well as limited healthcare access and also affordability, and also environmental and neighborhood barriers. And so I think all this to say that we have the perfect combination of both genetic and systemic factors to lead the charts in obesity, diabetes, and overall in chronic illness that kind of bring us here today. And so obviously this represents a tremendous economic cost, which a total economic hit of over $250 billion a year, including in public programs, employers, and even in the GDP drag. So I don't know if Ray has anything to say, but we could also go into the next slide. And so all this to say is that it's not getting any better. Just in the DC area alone and in Maryland, average SNAP benefits per person are just $187 per month. And, this is equivalent to approximately $6.16 a day. So, imagine affording 3 nutritious meals a day on just $6, which I don't think anybody comes close to the price of eggs today. So, I just want to give it up to Ray to just talk a little bit more about just the compounding and what that entails.
Great. So again, we see the issue of obesity just getting worse and worse. We can go to the next slide. Next slide. There we go. So GLP-1s, when they came on the market, haven't been on the market for a long time. You look at the end of 2019, 2020, they started getting to the market. By 2022, there's a shortage of GLP-1s. And then there's this huge kind of void that comes in, and the idea of compounding comes in. So if you go to the next slide. So compounding, just to break it down, like compounding, if your kid is like throwing up a pill, they go to the pharmacist and say, hey, this pill is not working for my kid. And they'll say, okay, let's mix it in with this, or let's split it in half. That's a form of compounding. That's what pharmacists are trained to do. And in many ways, if it's that interpersonal relationship between a person and the pharmacist or their doctor, they know exactly what it is. The issue also is GLP-1s are often injected. So once you inject the drug, there's no turning back. It's not you can like have your stomach pumped or something. It's like that the drug is in you. It's in the bloodstream at that point. And so one of the challenges that we found is that like when compounding started filling this void, it didn't do it on an individual basis. It did it for a compounding pharmacy in Kentucky or in Ohio. And they produced a lot of drugs for a lot of different folks in other states who they often didn't quite know. They didn't know their body chemistry. They didn't do retinal exams. They didn't know anything. So the people were starting ordering because they were cheaper, right? And so the shortage ended in May of 2025, but the flood of these compounded drugs started coming in. And so what we started seeing is these bad actors coming in using drugs that were for research, the basis of the drug for research use only. They're called RUOs. These RUOs are basically for lab mice and for lab pets. They're not made for humans, but they were being used for humans. They were not being FDA approved because they were just done in sometimes they were done in hotel rooms. So you're starting to see this flooding of these drugs on the market. Add to that, there's the actual fake drugs. Everyone who has, I have a friend, una tía que vive en la República Dominicana, like an aunt that lives in the Dominican Republic, and she can give me the Ozempic there. Is it really Ozempic? My sister lives in El Paso. There's a lot of, like, we go to the next slide. My sister lives in El Paso. What you're seeing is this kind of U-turn pharmacies, people going down to the border from El Paso to Ciudad Juárez in Mexico. And as soon as you cross the border, there's big billboards saying, hey, farmacias similares, lo mismo, pero más barato. Like pharmacy, biosimilar pharmacy or pharmacies, the same but cheaper. And what we're seeing this more and more and more, like we're seeing the outcome of it is these pharmacies are selling drugs illegally. These pharmacies are selling drugs that are becoming a bigger problem for state regulators. There's no capacity for actually regulating this drug to find out who it is. I think in the state of Illinois, just a few years back, they had like 86 pharmacies for one inspector. For that person to call and inspect the pharmacy is basically calling each pharmacy and say, hey, you good? That was basically it. And that was the extent of which the regulation was actually happening. Next slide. And of course, who gets the bill for it? So when you start experimenting with these little drugs and you start sending them out to different people, some people make a lot of money. And the ones that get the bill for it are the folks who are actually using it. And quite often, the folks who are most desperate, again, we don't have the health insurance to cover it. We have obesity. About 50% of our adults and 30% of our kids are obese. And then we see these fake drugs surging the market. We can't afford it, but you can afford these drugs, but they're not the right drugs. And so we're seeing this more and more. Next slide. I call this the Wild West in the syringe. As when you have the administration via FDA and DEA basically pushing a deregulation thing. Let the market sort themselves. If bad actors on the market are going to lose business, well, the bad actors don't quite lose business, because when they find out to be bad actors, they just move to another state and they change their name. So you see this over and over and over again. You see a lot of, we had this almost 15 years ago with the New England Compounding Center, when they were selling vials of meningitis vaccine that were contaminated. When they actually went into their labs, they found there was fungus in the vials. And so this was, like, again, a big disaster. 100 people dead, 700 people in the hospital. And Congress went back and said, let's do something about these compounding pharmacies. Now it's gotten even worse. Next slide. I'll turn it over to Andrea.
There we go. Yeah, and so as kind of like Ray mentioned, border states and online pharmacies are becoming the ground zero for these counterfeit medications. And so currently compounders operating all over in Texas, California, Arizona, and New Mexico are frequently cited for these kinds of violations, with the FDA warning letters issued towards Empower Pharmacies in Houston, Texas, and Fullerton Wellness in California. And so sometimes, like, these medications are coming in and they are labeled as research only and thus never really inspected by the FDA. Next slide, please. And so it's not just south of the border. This is also coming into online markets that are actually easily accessible for Latino communities, for everyone, right? Just a quick Google search and you're able to order up these medications without much regulatory oversight. Next slide. And so we know that it's also technically targeting Latinas and young women of color. Latinas and Black women have been aggressively targeted by special offers or the use of Spanish ads, or even like bodega flyers and social media influencers. We know that trends of the 90s and early 2000s in relationship to dieting culture and weight loss have been coming back, and now marketing just proves to be problematic and targeting our communities directly. And so we're kind of like the perfect target for them as well. So next slide, please. Yeah, and so, you know, we're already economically burdened enough. And so that leads also to our communities to seek these kinds of alternate avenues to obtain the wonder drugs, right, that are being pushed so hard by the media. Next slide. So here are some examples of this, you know, the counterfeit and the authentic drugs. We can see they're actually getting really clever with, you know, the imaging, and kind of really making it really difficult to actually differentiate between what's real and what isn't. And so, and now it's not just about counterfeit designer purses anymore. It's about real medications that are affecting our communities. So next slide. And so, you know, currently, as Ray mentioned before, we're actually working in a report together to further sharpen our focus on the burden of these adverse events that have been tied to compounding GLP-1s, particularly as it relates to Latino and Black communities. And so the lack of clear FDA regulation and also state enforcement surrounding these compounding practices and, you know, the counterfeit medications coming through is what we truly need to lean into. So I'll leave to Ray to talk a little more about that.
Yeah, we go to the next slide. So we see the number of misleading ads going up higher and higher. We see the Wegovy from Canada, the Wegovy from the US being very, very similar to the ads. These compounding pharmacies are getting very clever at how they do their marketing. Even the products that they sell look very similar to what the products that are actually real. What we're seeing this, so the question is like, okay, so we have Latinos who are high burden of obesity, high burden of limited access to healthcare coverage, and then there's a fourth part of the perfect storm is the deliberately predatory exploitation. So if you go to the next slide. If you saw the Super Bowl, you will see this ad from Hims and Hers. And I'll just say it because I think it was kind of very bold to basically say that, like, you could, like, the rich don't live longer, the rich have this. It was this kind of this populist, almost Trump-like, that we're going to, like, really democratize healthcare and access to medications, but with fake drugs, not real drugs. These are bootleg drugs. And so that was one of the things that really kind of just shocked me. It was like, wow, like, these are unregulated drugs. Of course you're going to have access to them, but they're not real drugs. Next slide. And so when Latinos are the sponge of misinformation, the way we consume information, first of all, it's WhatsApp, YouTube, and Facebook. That's where we get our news from. Almost over 50% of the news information that we get is from those three platforms. The other thing we also know is the misinformation, the fact checking, because we know from the meta leaks that 50% of the disinformation, like the fact checking budgets, was only for English. Spanish was under-enforced. So if I said COVID vaccine gives you cancer, 85% of the times it's flagged as misinformation. If I said la cura de COVID te puede dar cáncer, which is the same thing in Spanish, 85% of the time it went through. And then the way that Latinos consume information, especially Latino men, is that if we see it and we believe it, we're spreading the word like as if it's gospel. We're telling our friends and telling. So one of the chismosos, we're just like spreading the word as if it's gospel to other folks, and then people are more likely to believe it because we're trusted actors, right? We're family members. We have the uncle that's sending us a YouTube video. What we saw here. This is exactly the same problem. So again, we go to the next slide. So one of the things, the legislative wise, we filed a complaint with the National Consumer League. A lot of other organizations, including NHCOA, helped sign off on this letter. We had a meeting with them recently, about a few weeks ago, and it sounds like they're probably going to launch an investigation on the predatory marketing, particularly probably from Hims and Hers, because of the idea of like doctor supported, which is very misleading because it's like a doctor can support a medication, but if it's not approved by the FDA, it doesn't matter if it's doctor supported. The other bill that right now we're really advocating on the Hill on the federal level is the Safe Drugs Act. It's really it's an act that really kind of pushes more regulation from the feds to like start looking at what's getting into our sphere. If we know that more than 50% of people are ordering their drugs online, we got to make sure that the drugs that they're getting are actually the right drugs. They're not, again, once you inject it in your body, it's in, and it can do some serious damage. We know that also the number of cases of bad adverse events have increased by 1,500%. It's about 22,000 cases per year. So this is a very serious issue. And it's not only with GLP-1s. We're seeing it with like hormone replacement therapy, pain medications. We're seeing a lot of other bootleg drugs flooding the market in other spaces too. Next slide. Anybody, Andrea can probably tell you my wonderful quote that I say in the office, si hay trabajo, hay que trabajar. If there's work to be done. And I say this quite often because I think we're fighting it on multiple levels. We're fighting at the federal level, we're fighting at the regulatory level, but also in the state legislatures. And I wanted to just give you a quick list of the states that we're tracking right now and the bills that we're tracking specifically at the state level. LULAC has a wide network. We have about 435 councils. We have 570,000 members across the country. We're just a big, huge group of people. One of the things we've been very aggressive is to target it at these state levels to make sure that our local voices are represented in these state legislatures and testifying, writing letters, and reminding them that Latinos are disproportionately affected by this. And again, we want access to safe drugs. We want access to drugs. Ideally, the prices should go down, right? We want cheaper drugs. So no one's off the hook here. But we don't want to replace expensive drugs with fake drugs. That's basically, so the other thing is also reminding people on our social media platforms, it depends on the platform, but we're one of the most followed at the highest of Latino organizations. We're on TikTok and YouTube, Instagram, you name it, with a lot of followers, thousands of followers. So we try to use that as a voice to try to get information out there. And with that, I'll just conclude with that. If people have questions at the end, I have to jump off earlier, but that's all I have for now. Thank you to Andrea, and thank you to Jeff.
Yep, thank you, Dr. Serrano, and thank you, Andrea, for that informative presentation. Unfortunately for you guys, sometimes when you have a very informative presentation, you tend to get the most questions. So I just want to remind folks, you should have a question box at the bottom, and we will also have time for questions at the end. So thank you guys both. Our next speaker is going to talk about vaccinations throughout life, from childhood to adult. That's always been a key public health strategy to reduce preventable illnesses, and has helped people both taking the vaccination, but also helping people who aren't able to take the vaccination for whatever reason. And this area is one of the areas I've seen the biggest shift over the past few years. And so we are delighted to have our next speaker, Ms. Cristina Pacheco, who's the National Hispanic Council on Aging's Director of Policy and Development, to speak more about this topic. Welcome, Ms. Pacheco. And yep.
Thank you, Jeff. Thank you. All right, if we can go to the first slide. Next slide. So thank you, everyone, for allowing me to be here. Can you click one more time? Walter, thank you. So before I begin with data and policy, I want to share something personal. Pictured here is my maternal grandmother, Martha Louise Davis Cochran, and she contracted polio in 1954. She was 19 years old, newly married, healthy, and full of plans. Within weeks, she lost the ability to walk. She lived the rest of her life with the lasting effects of a disease that just 1 year later had a safe and effective vaccine. By 1979, polio was eliminated in the United States. Her story is a reminder that vaccine preventable diseases are not abstract. They change families for generations. Today, we have the tools that she didn't. The question before us is whether we will ensure that American families have access to them. Next slide. Vaccinations remain one of the most effective preventive tools in modern medicine. It protects children from preventable diseases, it reduces complications for adults living with chronic conditions, and it protects older adults who are often at the highest risk for severe outcomes. A lifespan approach is critical. Childhood immunizations lay the foundation for individual and community protection, but it also plays a protective role beyond that child. In many Latino families and families across the country, multi-generational households are common. Grandparents often live with and provide daily care for grandchildren. And when a child is not vaccinated and contracts a highly contagious disease, such as measles or influenza, that exposure does not stay confined to a classroom. It can quickly move into the household. Older adults, particularly those with diabetes, cardiovascular disease, or weakened immune systems, are significantly more likely to experience severe complications, hospitalizations, or even death from infections that may be mild in children. So when we talk about childhood vaccination, we are talking about protecting grandparents. Immunization is not just an individual decision, it's a household level and community level protection strategy. That's why a coordinated lifespan approach to vaccination is so important. Next slide. And while vaccination remains one of the most effective prevention tools we have, data shows measurable erosion in coverage across both children and adults. For measles, mumps, and rubella, or MMR, we aim for at least 95% of coverage to maintain herd protection. Yet during the 2024-2025 school year, 39 states reported MMR vaccination rates below that 95% threshold. Even more concerning is that 16 states reported coverage below 90%. Before the pandemic, only 3 states were below that level. And in the past year alone, over half of the states experienced declines across all required childhood vaccinations, so including MMR, DTaP, polio, and varicella. During the 2024-2025 flu season, vaccination coverage among children was at 50.2%. That's down more than 5 percentage points from the prior year and down 13.5% points from 2019 to 2020 flu season. In fact, it's the lowest seasonal flu vaccination coverage among children in the past 15 flu seasons. Among adults, flu vaccination coverage was at 41.9%. And after a brief increase during the pandemic, adult flu vaccination has steadily declined. For COVID, reported uptake of the updated 2025-2026 vaccination stands at 17.6% among adults overall, and about 33.7% among adults 65 and older, some of our most vulnerable. For children, COVID vaccination uptake is under 9%. Shingles vaccination rates remain particularly low. Only about 35% of eligible adults have received the vaccine, despite the fact that Shingrix is more than 90% effective. These declines may sound incremental, but remember that small percentage drops translate into thousands and sometimes millions of additional individuals at risk for avoidable illness, hospitalization, and long-term complications. And when vaccination coverage declines, healthcare costs rise. Next slide. As the previous presenters mentioned, barriers include things like cost and transportation, inconsistent provider access, misinformation, and confusion about ever-evolving recommendations. For Latino families in particular, structural barriers, including insurance gaps and language access, compound these challenges. Next slide. And again, when vaccination coverage declines, healthcare costs rise. The measles outbreak response alone can cost a state and local health department millions in containment and contract tracing. Influenza hospitalization averages between $10,000 and $15,000 per admission. Shingles complications can lead to chronic pain requiring ongoing care. And prevention is not just clinically effective, it's fiscally responsible. Next slide. So there have been several recent changes in vaccination guidance. There's updated COVID-19 booster recommendations that continue to evolve. RSV vaccines are now available for older adults and certain infant populations. New pneumococcal vaccines simplify adult schedules, and federal advisory and review processes have undergone structural changes affecting how recommendations are communicated. For families and providers, the pace can create confusion, and clear communication is essential for building trust. Next slide. We are seeing a significant shift in where and how Americans receive vaccination information and services. Pharmacies now administer a substantial share, and in many areas, the majority of adult vaccines in the United States. That has dramatically increased convenience and geographic access. Retail clinics, employer-based vaccination programs, and insurer-led outreach campaigns have become major points of entry into immunization. At the same time, the information environment has expanded beyond traditional public health channels. Social media platforms, private online forums, and employer communications increasingly shape vaccine perceptions, sometimes before a family ever hears from a clinician or a public health department official. The shift is not inherently negative. In many ways, it expands access, but it does change the communication landscape. Families may receive guidance from a pharmacy, an employer benefits portal, an insurance app, or social media before they encounter CDC guidance or a primary care provider's recommendations. And when vaccine recommendations evolve, as they have with RSV, COVID boosters, and pneumococcal schedules, coordination across these sectors becomes essential. Without clear, consistent messaging, confusion can increase, and confusion often leads to inaction. Next slide. Latino communities represent nearly 1 in 5 people in the United States. Higher rates of diabetes and cardiovascular disease increase vulnerability to severe complications from vaccine-preventable illnesses. Multi-generational households increase transmission risk when the vaccination rate declines. Gaps in adult vaccination disproportionately affect essential workforce families who cannot afford prolonged illnesses. And when adult vaccination rates are low, severe disease risks increase, not only for individuals, but across entire families. Next slide. In today's environment, families and clinicians rely on multiple professional and federal bodies for immunization guidance. The CDC publishes annual immunization schedules informed by expert review processes. Professional organizations such as the American Academy of Pediatrics and the American College of Obstetrics and Gynecology or gynecologists provide clinical guidance to their members. Advisory boards like ACIP review evidence and issue recommendations that shape national schedules. Organizations such as the National Adult and Influenza Immunization Summit and the Immunization Action Coalition support education and implementation efforts. What matters most for families is that the guidance remains clear, transparent, and grounded in evidence. Next slide. There are clear legislative pathways forward. Sustaining funding for immunization infrastructure ensures that states track coverage trends and respond quickly to outbreaks. The Vaccines for Children program remains one of the most successful public-private partnerships in public health, and it has played a critical role in maintaining childhood coverage nationwide. Ensuring zero-cost adult vaccine coverage under Medicare and Medicaid reduces one of the most persistent barriers, which is cost uncertainty. Investing in culturally responsive communication improves trust and uptake. Supporting pharmacies and community clinics strengthens access, but requires coordination across sectors. At the same time, we're seeing policy debates emerge in several states requiring vaccine requirements. For example, Florida is currently advancing legislation that would significantly weaken or eliminate certain vaccine mandates, including school entry requirements. Historically, school vaccination requirements have been one of the most effective tools for maintaining high coverage and preventing outbreaks for measles, polio, and other preventable diseases. When coverage drops below herd immunity thresholds, particularly for highly contagious diseases like measles, the risk of outbreaks increases rapidly. Policy decisions at the state level have direct implications for disease transmission, healthcare costs, and community protection. Policy stability and evidence-based decision-making promote public confidence. Sudden shifts in requirements or messaging can contribute to confusion and declining uptake. Ultimately, immunization policy is not theoretical. It determines whether preventable diseases remain rare or reemerge. Next slide. So vaccines remain a fundamental prevention tool. As guidance evolves and private sector influence grows, lawmakers play a critical role in ensuring consistent access, clear communication, and sustained infrastructure. Protecting children, adults, and older adults requires coordinated policy action. I began my talk today with my grandmother's story. She contracted polio 1 year before the vaccine was declared safe and effective. She never had the opportunity to prevent it. Today, families do. The question is whether we will ensure that access is clear, affordable, and trusted across the lifespan, from childhood through adulthood and older age. Immunization policy is not abstract. It determines whether preventable disease becomes a lifelong burden or a chapter in history. Thank you. Jeff, sorry, I think you're muted.
Oh, so sorry. Thank you so much, both for the excellent presentation and also for flagging that for me. Again, there is a question box at the bottom of your screen. So if folks have questions, you could put it in now, and we'll also have an opportunity at the end for folks to ask questions. Continuing to our next topic, we are going to talk about the 340B drug pricing program. So this is a federal program that allows eligible healthcare providers, particularly those serving underserved populations like the Latino community, to purchase outpatient drugs at reduced prices. So in theory, it sounds like it could really help our community, but unfortunately, we have seen healthcare providers abuse and exploit this program. And so we are delighted to have our next speaker, Mr. Johnson, who's the executive director of ASAP 340B, which is an organization concerned with ensuring the viability of the program, and is going to provide us an overview of this complex issue. So welcome, Mr. Johnson.
Yep, thank you. And thank you, everyone, for having me as part of this program. And thank you to the National Hispanic Council on Aging as well. I'm going to talk a little bit about our coalition, talk about the program and how it works and how it's supposed to work, some of the concerns that we have with regards to the program, and we'll talk about steps forward. Next slide. So we have 44 partners as part of our coalition. We're happy to say that National Hispanic Council on Aging, LULAC, are also members of our coalition. In total, we have 44 members, and we continue to grow. We started at 17. Some of our newest members include the NAACP, Prevent Blindness, and the Tiger Lily Foundation. Next slide. So we've come together around the fact that Congress created the 340B program over 30 years ago to help low-income and other vulnerable patients access more affordable medicines. The community health centers and other safety net providers rely on this program to serve their communities. Some entities participating in this program have taken advantage of the lack of clarity at the expense of patients that it's meant to serve. And the well-being of communities at this time served by our country's healthcare safety net is at stake. Next slide. So here's an outline of what's supposed to happen with regards to the 340B program. The 340B program is a drug discount program for outpatients where certain covered entities are able to obtain drugs at a discounted price from the manufacturer. The manufacturer signs agreements with covered entities such as hospitals, community health centers, and other types of covered entities as defined by the statute. And the average discount is 59% of the cost, acquisition cost of the drug. The drug is then dispensed by that covered entity to the patient. Patient's insurance, such as Medicaid and other public programs and private insurance, is then billed for the actual full cost of the drug, and the covered entity is allowed to keep the difference. So that is the way the program is supposed to work. Unfortunately, what's happened is that there are a number of covered entities, particularly hospital systems, that once they are have acquired the drug under the program, they turn around and they bill Medicaid, Medicare, and other payers much more than that difference between the discount and the acquisition cost. In some cases, to the tune of 500 to 1,000%. And PBMs help them create this price through spread pricing. And patients are not benefiting from this practice. And that's one of the many things that we're concerned about with regards to this program. Next slide. So this program is not working as intended in many areas. There's a total of $81.4 billion of total discounted purchases in 2024. 87% of those purchases were made by hospitals, and the other 13% were made by the other types of covered entities under the program. The program has expanded significantly. There are very few transparency and accountability measures, so we really don't know if the money that is used by these covered entities, that difference that we talked about, is being used for healthcare. And we have many instances where it's not being used for healthcare, but it's being used for capital improvement projects, it's being used for Super Bowl ads, and it's being used to pay the salaries of football coaches, amongst other things. The program currently, unfortunately, encourages hospital consolidation and those benefits flowing away from low-income communities as hospitals prioritize patients with higher paying private insurance. And again, PBMs and other middlemen are siphoning billions from the program, as last reported, up to the tune of $2.5 billion. Next slide. There's been activity in Washington to try and find a comprehensive federal solution in 2024. There are a number of bills, two bills in particular, that either were introduced or are being worked on. 340B Access Act, introduced by Representative Bouchon, that's been reintroduced by Representative Carter in this Congress. The Sustain Act, which is a draft that is being circulated amongst a number of senators called the Gang of Six that are continuing to work on this draft. Those are both comprehensive measures to try and address the number of concerns that many have as it relates to the 340B program. The Gang of Eight is meeting, and they continue to meet. There's a new iteration of that Gang of Six with new members currently. And there has been some interest even on the House side to create a similar bipartisan working group to move forward with some type of reform measure. Senator Cassidy, who chairs the Help Committee, has been very active in investigating concerns about the program, and indeed issued a report last April, outlined many of those concerns, which I'm going to touch on. Currently, there's been some discussion about possibly moving forward on the administration side with a drug rebate model. There are a lot of concerns, pro and con, concerning moving forward with that type of approach. Our coalition has not endorsed that model, but it is something that is being monitored by many, many groups, and the administration is continuing to work on getting input as to what that model might look like. Next slide. So I talked about Senator Cassidy's report. These are some of the findings that came from that report, noting in certain instances how the program is being misused. The Cleveland Clinic generated nearly $1 billion in 340B revenue, none of which was passed directly to patients. Instead, it was absorbed into operating budgets and capital projects. Next slide. Bon Secours Mercy Health in Richmond, Virginia, in an article outlined nationally, despite being located in one of Richmond's poorest communities, Bon Secours used its 340B profits to fund expansion into wealthier areas, understanding that this is a program for the underserved, and patients at Richmond Community Hospital saw no direct benefit from the savings. Next slide. Sun River Health generated over $100 million through 340B, primarily from HIV/AIDS, diabetes, and hepatitis C medications. 3 of its 30 clinics produced over 50% of the program's total revenue. Next slide. So we talk about accountability with regard to this program. And the differences really are stark with regards to the type of accountability that applies for those covered entities that have a status as HRSA grantees, which includes community health centers, where they qualify for 340B as a federal grantee. They're required to report how a grant funds are being used and how those savings are being used. They reinvest savings back into patient care, and they have an income-based sliding fee schedule for patient drug copays. Compare this with 340B hospitals. They qualify for 340B by serving a disproportionate share of low-income patients, but there are no federal requirements in the statute to report how 340B savings are used for those hospitals. There's no obligation to reinvest savings into patient care. And in terms of requirement to provide charity care, 2/3 of those DSH hospitals were below the national average of 2.5% of operating costs. Next slide. And you can see here the relationship between 340B hospitals and charity care, where 340B hospitals are providing less in terms of percentage charity care than nonprofit hospitals and for-profit hospitals. Next slide. In one instance, in the cancer area, these abuses are really outlined in a stark way. 340B hospitals tend to use higher cost cancer drugs, resulting in larger profit margins. Revenue earned by those hospitals for cancer therapies was over 10 times higher than at non-340B hospitals. In one case, a patient was billed $22,700 for a drug that cost the hospital $2,700. Next slide. December 2024, there were 13 health equity advocacy groups that wrote a separate letter calling for reform. Many of these groups are members of our coalition to date. Next slide. And we list a number of Latino organizations that are part of our coalition, including LULAC and the National Hispanic Council on Aging. Next slide. So solutions that we think are important in this debate are: one, ensuring that savings are used to help patients and true safety net providers, prevent abuse by middlemen, and verify that this important program is working. Next slide. You can find out more about our coalition by going to our website at www.asap340b.org to learn more. And thank you, Jeff.
Great. Thank you, Mr. Johnson. I loved how diplomatic you were in talking about the college who used profits to hire a head coach. And I won't say it either, but if people are looking for another reason to cheer against the University of Miami, I'm sure you could Google and find some reasons to root against them. Our next topic is the Older Americans Act, which is just a critical program. So many programs like Meals on Wheels, LIHEAP, even pension counseling, CSEP to train seniors are funded through the Older Americans Act. I could list, there's 20, 30, more super important programs. But it's just so critical to our community. And in the last years, we've seen some changes in regards to it in the reauthorization of this important law. And so we're delighted to be joined by Mr. Trin, who is the National Director of the Diverse Elders Coalition. So welcome, and we look forward to a great presentation.
Hey, thank you, Jeff. Good morning, everyone. Happy Black History Month, and thank you to Dr. Cruz and the National Hispanic Council on Aging for the invitation to join this important and timely briefing. Next slide, please. My name is Didier Trin. and I use he, him pronouns. I serve as the national director, as Jeff mentioned, of the Diverse Elders Coalition, or DEC, and I am based in Washington, D.C. You can see here we have a small but mighty team supporting the work of the coalition. Next slide. Founded in 2010, the DEC includes 6 national organizations representing older adults and caregivers from the diverse communities that you can see on this slide. I would be remiss if I did not mention that one of our founding members is our host today, the National Hispanic Council on Aging. Individually, our member organizations have and continue to provide programming for older adults and family caregivers in their respective communities, and are viewed as trusted leaders in their settings. Their work is also inclusive of other communities, accounting for the intersectionalities of our diverse communities. Together, we advocate for policies and programs that improve aging in all communities. Next slide, please. I'm pleased to be here today to share an overview of the Older Americans Act, or OAA for short. For 6 full decades, the OAA has provided services to older adults and their caregivers to live with dignity as they age. The OAA was first passed and signed into law in 1965 alongside Medicare and Medicaid. And since then, lawmakers have advanced many bipartisan updates to this legislation that enable people to age at home and in the community where they overwhelmingly want to be. Through the OAA, the Administration on Aging, as well as the Administration for Community Living at the U.S. Department of Health and Human Services, exists to administer federal grants to states to support older adults around the country. Next slide. Supporting close to 12 million older adults and caregivers on an annual basis, the OAA funds states and local agencies to deliver critical services, including but not limited to nutrition, transportation, in-home supports, health promotion and disease prevention, and caregiver supports. However, to provide a point of reference, as of 2024, there are more than 61 million people aged 65 and older in the United States, representing 18% of the total population. It is also 5 times the number of people served by the Older Americans Act. This demographic has grown significantly due to the aging baby boomer generation, with projections now that the number of older adults will reach over 82 million by 2050, which is less than 25 years away. On the caregiving front, as pointed out in this slide, funds covered under the Older Americans Act also enable HHS to develop, update, and improve the national strategy to support family caregivers, which was launched in 2022 and is set to be updated this year. The national strategy represents the first time that a broad cross-section of the federal government has collaborated with the private sector on a dedicated response to the long-standing national need for a comprehensive system of family caregiver support. The strategy includes nearly 350 actions at the federal level and more than 150 actions that can be adopted at other levels of government and across the private sector to build a national infrastructure that ensures family caregivers have the resources that they need to maintain their own health, their well-being, and financial security. Next slide, please. As you can see here, OAA services are delivered at the state and local levels through a wide national network. Next slide. The National Hispanic Council on Aging is one such implementer as one of 5 ACL-funded technical assistance and resource centers that provide needed education and outreach to minority populations. Next slide. The OAA statute itself includes 7 distinct titles covering a range of programs and services for older adults. Nearly 3/4 or 72% of OAA funding provides grants to states and community providers for nutrition services, caregiver services, and other social services. Next slide. As evidenced by the next few slides, a broad spectrum of essential services reach older adults through the Older Americans Act. However, with additional funding and education for the OAA, so many more could benefit. Next slide. I won't tick off the specific numbers, but you can see all the supports the OAA offers and currently provides. Next slide. The National Family Caregiving Support Program is a critical piece of the Older Americans Act that demands continued funding by Congress. I want to note that Congress recently passed modest increases as part of the fiscal year 2026 appropriations for the National Family Caregiver Support Program, Native American Caregiver Support Program, Lifespan Respite Care Program, and the National Strategy to Support Family Caregivers that I mentioned earlier, demonstrating growing bipartisan support for addressing our nation's worsening family care crisis. Next slide. The Older Americans Act, as part of that, provides crucial services to Hispanic and Latino older adults, with about 10% of home and community-based service recipients identifying as Hispanic in 2020. In fact, the OAA focuses on serving low-income, minority, and high-need older adults. As of 2020, there were an estimated 4.6 million Latino and Hispanic adults aged 65 and older in the United States, comprising 9% of the older population. This demographic is the fastest growing minority group among older adults, with projections showing the population growing to upwards of 20 million by 2060, when they will account for 21% of all US older adults. It should be noted that Hispanic and Latino participants in OAA programs are more likely to be low income, disabled, and Medicaid recipients compared to non-Hispanic participants. Barriers to access include a lack of Spanish language information, insufficient bilingual staff, and fear of immigration status scrutiny. Next slide, please. To give you a sense of the demographics of OAA recipients of Title III services, according to a KFF analysis of ACL data, 4 out of 10 OAA recipients are living in poverty, 3 out of 10 reside in rural areas, and a third are people of color. Next slide. The OAA includes Title V on the Senior Community Service Employment Program, or CSEP, which is a community service and work-based job training program for older Americans. CSEP participants gain work experience in a variety of community service activities at both nonprofit and public facilities, including schools, hospitals, daycare centers, and senior centers. The CSEP program provides over 40 million community service hours to public and nonprofit agencies, allowing them to provide it to provide needed services. Participants work on average 20 hours a week and are paid the highest of federal, state, or local minimum wage. This is critical training that allows older people to stay involved in their communities, and the training serves as a bridge to unsubsidized employment opportunities for those participants. Next slide. The OAA also includes Title VI, which is targeted at social supports for older American, Indian, and Alaska Natives, as well as Native Hawaiians. Next slide. Each state is required to operate a statewide Office of the Long-Term Care Ombudsman to provide quality of life and care of residents of long-term care facilities, including individuals who live in nursing homes and assisted living facilities, as well as to more broadly advocate on behalf of those residents. These services help support the 6 million people on Medicaid who live in institutional settings. Next slide. As you can see from this KFF analysis, the rate of funding increases for the Older Americans Act has not come close to keeping pace with the growth in older Americans over the past decade. The OAA over the years has been reauthorized and amended several times, including most recently through the Supporting Older Americans Act of 2020, which authorized appropriations for OAA programs through fiscal year 2024. Given that it is now 2026, obviously the reauthorization has lapsed. The most recent congressional activity occurred in late 2024 when the Senate unanimously passed the Older Americans Act Reauthorization Act of 2024, which would have reauthorized the OAA for another 5 years. The House then introduced legislation that included reauthorization of the OAA, but unfortunately the funding deal fell apart as a result of pressure from then President-elect Donald Trump. Subsequent legislation passed by Congress to keep the government funded did not include reauthorization of the Older Americans Act. So the good news is that the exact same version of the bipartisan bill that passed unanimously in the Senate in 2024 has been reintroduced on a bipartisan basis this Congress. For those who are interested, the bill number is S2120, and the DEC continues to advocate for Congress to reauthorize the Older Americans Act. Next slide. The John A. Hartford Foundation, which has funded DEC's caregiver research and policy advocacy since 2018, commissioned a survey last year of more than 1,100 US adults age 18 and over to understand their views on supporting community programs for older adults and the Older Americans Act. This next set of slides highlights some of the survey findings. First, the programs funded by the Older Americans Act are supported by more than 4 in 5 US adults. Next slide. Support for these programs is high, regardless of age, race or ethnicity, or where people live. Next slide. Support is also very strong for the Older Americans Act to be funded by the federal government, regardless of party affiliation. Next slide. Nearly 4 in 5 adults support using federal tax revenue to fund programs that help people age at home and in their community. Next slide. Nearly 7 in 10 adults support using federal taxes for programs that help keep older adults active and engaged in their community. Next slide. Using tax revenue to help prevent elder abuse, neglect, and exploitation is supported again by 4 in 5 adults. So you see a recurring theme here that a solid 80% or more of Americans strongly support programs that are available through the Older Americans Act. I'm going to just include a link to the survey for those who are interested in digging a little bit deeper. Next slide, please. The Diverse Elders Coalition, as I mentioned earlier, has been advocating for the reauthorization of the Older Americans Act. I'll just mention here some of our priorities for OAA, including expanding populations of greatest social need, enhancing data collection on the needs of family caregivers, maintaining flexibility for ease of access to services, increasing language access services, and ensuring more inclusive definitions of family caregivers beyond blood relatives. Next slide. I also wanted to mention that the Diverse Elders Coalition is excited to launch a new partnership with Sage Care on the needs of diverse caregivers. Sage Care's mission is to foster affirming environments across all levels and types of care and empower culturally competent trauma-enforced services. As I mentioned previously, the Diverse Elders Coalition, through the support of the John A. Hartford Foundation, has been doing research on the needs of diverse family caregivers, including developing a curriculum for providers to better support the needs of diverse caregivers. Last year, we undertook a new targeted literature review to ensure relevance and expanded inclusion. This research incorporated a stronger focus on the direct care workforce, as well as a stronger emphasis on intersectional communities. As we relaunch this updated training in the coming months with Sage Care, we really see policy advocacy and community storytelling as the key pathways for systems change. Next slide, please. We have also developed a new policy toolkit based on this updated research. It is organized around DEC's core policy pillars and will continue to inform our advocacy on the Older Americans Act, in particular around caregiver supports. Next slide. Thank you for your continued support of diverse communities as well as of the Older Americans Act. And I'll turn it back over to Jeff.
Great, thank you. And please stay on. And if other panelists want to join us, we have two amazing speakers that are going to give concluding remarks. I see Bob Blancato there, but we're going to ask a few of the audience questions first. And so I'll get to that in a second. And then I also wanted to highlight, you were talking about caregiving, and one of our allies in Congress, Congressman Jimmy Gomez, who's just been fighting for Latinos left and right. He is also the chair of the Dad's Caucus, and they are organizing a summit on caregiving that's going to be March 17th, also St. Patrick's Day, so easy to remember. And if you tune in virtually and have your camera off, no one will know if you're drinking a Guinness while watching. But they should be announcing that shortly. So people interested in caregiving, there's going to be a summit. It's going to include paid leave and several other topics. And so, again, they should have the invite out shortly if it's not out already. And that's going to be an amazing, amazing event. Mr. Trent, since you are still on, you talked about the popularity of the Older Americans Act. I think you said 84% of folks support it. And sometimes that support doesn't always translate into congressional action. And so what could someone listening to this at home do to help advocate for the program?
I think it's critical that not just older adults around the country who benefit from OAA programs, but their loved ones as caregivers, as people who recognize the needs of older people around the country, contact their elected officials in both the House and Senate at the federal level to urge them to reauthorize the Older Americans Act. As I mentioned in my presentation, It lapsed in the fall of 2024. We are coming on 2 years without authorized funding for the Older Americans Act. Fortunately, also, as I mentioned, appropriations for certain programs in the Older Americans Act continues to move forward, but authorizing legislation is critical to ensure the long-term sustainability of these programs. It also enables state and local agencies to plan effectively and implement these programs according to the needs of their communities. I'm happy to see Daniel from the National Council on Aging on the call as well. NCOA is an incredibly important advocate for the Older Americans Act. So the long and short of it is that we need those in local communities to contact their respective officials at the federal level and urge them to get the OAA done.
Absolutely. Thank you. Mr. Johnson, so, sometimes Congress needs to pass laws to make people do the right thing, but oftentimes, sunlight is the best disinfectant. And just having transparency where companies have to report what's going on could be a powerful tool to make folks do the right thing. And so, my question is, how can Congress improve transparency so we better know how 340B dollars are being used?
Well, I think they've got to pass legislation to get that to take place. And I will tell you that there was a meeting of the Help Committee that took place last year during the government shutdown, and they had an oversight hearing on the 340B program. And it was interesting to hear that senators on both sides of the aisle, senators that were part of the Gang of Six, agreed that there should be some type of transparency and reporting measures. Tammy Baldwin from Wisconsin, who's part of the committee and is part of the Gang of Six, and has been since its inception, was very pointed in her remarks about the program needing some type of transparency and reporting. And so really, what I would say is, I think for all groups that want to see reform of the program, whether they are in our coalition or outside of our coalition, I think that's a thing that kind of holds us together, and that's a common thread for advocates of reform. This is the second largest prescription drug discount program in the country. In a couple of years, it will be the largest. And to have no transparency as to how 87% of the dollars that are spent in this program, there's no requirement for that. I think increasingly, not only do health advocates find that outrageous, but I think consumers find it outrageous. And there is really no reason why we can't open this black box and move forward with getting the data that we need to know where money is being spent and what it's being used for. And I guarantee you that if we do achieve full transparency, then maybe some of those spending practices, Jeff, on salaries of football coaches and such, I think they might magically go away.
Absolutely. Thank you. And so before I introduce our two amazing speakers for concluding remarks, I want to ask one last question from the audience. And this is open for everyone. And that question is about vaccinations. And, how could we convince people to trust vaccinations? And, sometimes the Latino community in particular is subject to a lot of misinformation. In English, stuff gets flagged very quickly, but in Spanish, we see just tons of misinformation going around. So, to the extent possible, what can we do about that, particularly in the Latino community? But how could we convince people to trust vaccinations is the question. Do either of you guys want to take a swing?
Well, I'll take the first swing, and this is not within the subject area of our coalition, but frankly, the science is there, the outcomes are there, the history is there, and frankly, at each step historically, the effectiveness of vaccines are reviewed and challenged, and are in an evidence-based way. And to get away from that because of a philosophy, I think is extremely worrisome. And any person who interacts with the healthcare system should talk to their doctor about that, and should talk to many groups. The American Public Health Association, I think, does a great job in leading the discussion about the cause for vaccines and what they've done in polio and other areas. There are many voices from different sides of the aisle that recognize the importance of vaccines.
Absolutely.
And,
And Mr.
I'll just be brief, Jeff. Agree completely with Thomas's remarks. I think we can just look at the recent and ongoing measles outbreak across the country as a perfect illustration of why, in this case, the MMR vaccine, which has been proven to be 97% effective, is critical to not just protecting children, but communities. And so I second what Thomas said about the science and the evidence over decades and decades of research and testing, that not only do diverse communities need this information, but they also need accurate information on the effectiveness of vaccines.
Yes, and Jeff, I know that Cristina Pacheco had some technical difficulties, but she wanted me to let you know that, regarding the answer of the questions, it will be like we need trusted messengers, and also the messages need to be consistent in a culturally and linguistically appropriate way to our community, and also to other diverse communities as well.
Absolutely, and I could relate to having technical difficulties. I'm glad it's not me this time. Fine and great answers to all our panelists. And so I want to introduce our first speaker to give concluding remarks, and that's Mr. Daniel Wilson, who is the Senior Director of Government Affairs and Advocacy at the National Council on Aging. And for those of us in DC who've been in DC for a while advocating, he's been a true champion and great ally to work with. And so I'm honored to introduce him. Mr.
Thank
Wilson?
you, Jeff.
Yep.
Yes, thank you, Jeff. First of all, I want to thank Dr. Cruz and the National Hispanic Council on Aging for hosting this important forum today. As we know, advocacy and education are so important and so critical during this day and time. Just to give you a quick example, when we talk about the Medicaid, when we look at HR1 and the Medicaid fight that happened, very few people recognize that Medicaid is the long-term care provider and funder for individuals living with a disability or older adults. And so there was a coalition and a group of us that were on the Hill, actively working and advocating to educate members of Congress and their staff that while many people equate Medicaid with expectant mothers, women, and children, there's also this big group of older adults and individuals who live with a disability that would not be able to age in place at home or in community settings or with their loved ones for funding from Medicaid. So that's really when we look at the importance of advocacy. I'll just leave you with this quick closing thought. When you look at members of Congress that are aging advocates, we have Congresswoman Jan Schakowsky, who's retiring this year. We have Congresswoman Matsui from the great state of California. Then when we look on the Senate side, we have Senator Rick Scott, who is the chair for Senate Select Committee on Aging, and we have Senator Kirsten Gillibrand, who is the ranking member. And so when we think about aging programs and advocacy and education, we really want to be targeted and talking to those members. But we also want to expand that out and talk to other members. So I encourage those of you who are here today to make sure that you get to know your members of Congress. You get to know those individuals and those programs, that they're well educated on what you're doing in the community. So again, I thank Dr. Cruz. I thank the National Hispanic Council on Aging for hosting this important forum. And Jeff, always good to see you. And thank you for moderating this great session today.
Absolutely. And we also have another distinguished champion of seniors to give concluding remarks, Robert Bob Blancato, who's also a member of the National Hispanic Council on Aging's Board of Directors. He's a member of the National Academy of Social Insurance. I just saw him at the conference last week. Good to see you again, Bob. And one of the most informed people in DC about the Older Americans Act and other topics. And so we look forward to your insight, Bob. Take it away.
Jeff, thank you very much. It's so nice to see all my friends on this screen here. And Thomas Johnson, I look forward to meeting you sometime. And everybody else, and Dieter, you did a nice job as always. And so let me first by saying, as a proud board member of National Hispanic Council on Aging, I'm very happy to help close this briefing. I want to thank Yanira for her constant focus on education and advocacy for the Latino community, and Christine Perez for her great work in coordinating these wonderful things. Needless to say, we continue to live in interesting times. From one day to the next, we don't know what to expect. But the topics you're focusing on today are vitally important at all times of the year. So let's go to the first slide. First, focusing on obesity and concerns about obesity. You're absolutely correct to focus attention on obesity. But you raised two important issues. One, the unfortunate development of dissemination of counterfeit and potentially dangerous anti-obesity medications, and the misuse of the 340B drug pricing program. These are matters of concern. They need to be addressed and remedied. But there are more positive things to focus on. So go to the next slide. The Treat and Reduce Obesity Act, or TROA. There is an opportunity for the passage of this bipartisan bill, which I know NHCOA has been very involved in and provided important support. We got to look at obesity as what it is, a major intergenerational health issue. 2 in 5 adults are obese, more than a quarter of older adults are obese, and childhood obesity has doubled since 1990. Now, last year, the administration expanded coverage for GLP medications, which was a major policy shift. TROA would complement this by expanding Medicare coverage of intensive behavioral counseling for obesity care. Next slide. And something we focus on a lot, and we wrote a piece in Health Affairs about this. Any obesity care plan must include nutrition, okay? And let's hope that if TROA does move in a larger health bill later this year, we can ensure that nutrition care is included in TROA and any other work in the area of obesity. Next slide. Another area of focus that's getting more attention is about medical nutrition therapy. This could be the year we finally expand medical nutrition therapy. Today, it only covers those with diabetes and kidney disease. The bill HR 6199 would expand coverage to cancer, heart disease, malnutrition, and obesity. And a recent study pointed to that if you expand MNT, it could lead to up to $33 million in savings through fewer hospital and outpatient visits. Again, with the hope of a comprehensive healthcare bill, this could include MNT expansion, because MNT is personalized, disease-specific nutrition counseling by a registered dietitian and nutritionist. A very important thing. Next slide. Many of you know about the increased focus on food as medicine. We are continuing to see progress here as well. Excuse me. We have the Medically Tailored Meal Act. We have Centers for Medicare and Medicaid Services proposing MAHA Elevate model and the Balance model to test how lifestyle and nutrition interventions can reduce hospitalizations and healthcare spending for high-risk individuals in Medicare, and Balance providing lifestyle support programs for those on anti-obesity medications. We could see in 2026 food as medicine moving towards scalable payment models, which would be a wonderful development. Next slide. So maybe 2026 will be a nourishing policy year. It began with the release of the new dietary guidelines for America, which, as you know, are the blueprint for major federal nutrition programs to follow. Like everything else coming out of HHS these days, they have generated a lot of debate, but they do also create a window of opportunity for policy change. The good parts, they emphasize more protein, avoiding highly processed foods, and the continued elevation of whole foods. But next slide talks about, they're not perfect by any sense. They do not provide enough guidance for older adults and those with chronic disease. We would like to see them address common issues like muscle loss and malnutrition. But for the DGAs to advance, there's got to be investment by Congress. The opportunity is certainly there for that to happen. Next slide talks about something that we work closely with NHCOA on, with our Defeat Malnutrition Today coalition, to have the first ever malnutrition quality measure adopted by CMS back in 2022. It's now called the Malnutrition Care Score, but CMS on their own, without any prompting from anybody, decided to make it for people 18 and above, not just 65 and above. And most recently, they've asked for the feasibility of adding this malnutrition care score to outpatient quality measures beyond hospitals, which would mean it would increase malnutrition screening, assessment, and diagnosis, and treatment across care settings for various conditions, including oncology. And the comments have closed, and we have submitted some. And let's point out the fact that this was motivated by a major Washington Post article, which spotlighted a major spike in malnutrition rates among people 85 years and over. Next slide. So two other issues on the horizon. I know Didier just talked about the reauthorization of the Older Americans Act. It's the largest program is the senior nutrition program, providing congregate and home delivered meals. The bipartisan bill S2120, which we have endorsed, most every aging organization has endorsed, would extend the law for 4 years with increased authorization. It also contains language that we advocated from our Defeat Malnutrition Coalition for malnutrition screening being covered in the Act. And finally, we also are waiting for more information on the rural health transformation grants that have been provided to all 50 states. We want to see how much is going to go for nutrition services, including nutrition CMEs for clinicians to be included to help rural older adults who face real barriers to food and medical access. Next slide. The other thing that you spoke about is the issue of, well, let me go back a second. What lies ahead? Not everything in the nutrition space is good news. Let me go back to the previous one. I'm sorry, I jumped ahead a little bit there. We have the issue of HR 1, which I know has come up in this webinar, the major cuts to Medicaid and the new work requirements for SNAP. A report that I just read this morning says that the number of people on food stamps or the SNAP program declined by 2.6 million from November 2024 to November 2025. According to the Agriculture Department itself. This is before the work requirements kick in every state. And this is before the work requirements, which now go to age 64, kick in. So we have got to be on top of dealing with some SNAP reforms in the Farm Bill, which is coming up later this year. But I think the majority of what lies ahead in 2026 could be positive. Depends on how they advance with making America healthy again, having nutrition as a centerpiece. We're waiting anxiously what CMS is going to come out with next on potential new social care reimbursement codes, which if they're allowed to happen could be a game changer for many, many programs that we care about. Then, of course, mentioning MNT and TROA and the Older Americans Act, and expanded use of the malnutrition care score in age-friendly health systems. Now let's go to the next slide. The other area you want to talk about, well, I'm still on this one here, okay. Go to the next slide, because I want to keep on time here for you guys. So vaccine access. I heard you talk a little bit about this when I came on. Your concern about vaccines for children and adults is warranted. My organization, NANASP, and of which we're proud to have Yanira as a board member, working regularly with her, has advocated for older adults to have the most complete access to up-to-date vaccines from everything from flu to pneumonia to COVID and RSV. Our efforts have been making great headway until this current administration began to weaken these protections. One particular decision was now to condition access to the COVID-19 vaccine for older adults on what's called shared clinical decision making. Okay, a process that neither the provider nor the consumer wants to do and can lead to non-use of the vaccine by an older adult who just may not want to go through the effort of going through shared decision making. Next slide. So the area that we're focused on right now is maintaining the free vaccines for older adults. Okay, there are no copays established right now for vaccines under current rules. And since 2023, copays have been waived for many of the vaccines recommended by the Advisory Committee on Immunization Practices. But we cannot get clarification on what happened at the end of this year. And we sent a letter on February 10th to the CMS administrator asking for his commitment to no vaccine copays beyond 2026. And Dr. Oz himself has said on 2 public occasions in the past 2 weeks that CMS will fund any vaccine you want. Okay, that's great. We want to hear that, but we want to hear go past December 31st of 2026. And, you know, flu seasons and pneumonia seasons stretch into the following year. And to have the thing end on December 31st of 2026 would defeat the whole purpose of what was there before. So we're awaiting the response of Dr. Oz on this, and we'll share that with everyone. So with that, I believe I will just have a bunch of resources here for folks who want to follow up. And of course, as is my custom, if people want these slides, they will be available. And thank you very much for the chance to join you today.
Great. Thank you, Bob. And thank you to all of our speakers and everyone tuning in. Just a couple of reminders, save the dates. Next week at 9 a.m. will be a virtual live stream for the rollout of the SSI Restoration Act. And of course, myself and Dr. Cruz will be the big draw as speakers. But we also have this Senator Elizabeth Warren. Maybe some of you guys have heard of her. We will have Representative Grijalva. We will have Representative James Moyland, who's a Republican, and bringing a couple of his Republican friends on board the bill. So we'll have strong bipartisan support for the first time. And, it's going to be a great event. And we will be getting that information out later today on National Hispanic Council on Aging, social media, our social media, etc. Also save the date for 10 a.m. April 21st, which is when National Hispanic Council on Aging will be hosting its next briefing, which will be both in person for those that can make it to the Hill, but also we'll have a virtual component. And then lastly, again, for those interested in caregiving, our friend and ally, Congressman Jimmy Gomez, will be hosting a summit on caregiving that day. And we'll be sending out more information very soon if they haven't already. I haven't checked in a while, but it's coming. So please mark those 3 great events, in your calendar, save the date. And I also want to remind folks that people who want to become partners, National Hispanic Council on Aging has an individual membership program. And for just $25, you could get access to exclusive resources, educational workshops, advocacy tools, and bilingual information on health and aging, all while supporting a great organization. And so to learn more, they have a QR code that you could scan. I'm not very tech savvy. You could also just, type in their website, NHCOA.org, and, find out more information that way. And again, follow them on social media. They have today's webinar and a whole host of other useful information on a YouTube channel. They have Facebook, X, formerly Twitter, and Instagram. So you could just use @NHCAO. It's also on your screen to get more information and news on upcoming events and what's going on in Congress that impacts our community. So please check out all of those resources. And thank you guys all for tuning in and have a wonderful day.